In the last several decades, cochlear implantations developed from an uncommon operation performed for profoundly deaf adults to one that's being done in patients with residual hearing, single-sided deafness, and in children with prelingual deafness under 1 year of age. Cochlear implantation has now been performed over 1 million times worldwide. And while many patients have great hearing outcomes after cochlear implantation, average performance on word and sentence recognition hasn't improved all that much in recent years. Cochlear implants are able to restore a patient's ability to hear by electrically stimulating neural sites within the cochlea with a surgically implanted electrode array. Some factors affecting speech understanding after implantation aren't modifiable. The cochlea in a patient with severe hearing loss may already have a significantly reduced number of spiral ganglion cells, though this may differ depending on the cause of the hearing loss. Cochlear implants have become the standard of care in treatment of moderate to profound sensorineural hearing loss in individuals who fail to benefit from conventional amplification. And the degree of hearing improvement in CI recipients is widely variable, and it's been shown to be affected by many patient-specific factors, such as preoperative hearing thresholds, medical comorbidities, and duration of hearing loss. Electrode array designs, insertion techniques, and surgical approaches seek to balance optimal electrode placement and hearing outcomes with the risk of insertion trauma. While we can't change many of these patient factors, we know that optimizing the insertion of the electrode array and decreasing the risk of insertional trauma leads to improved hearing outcomes. In patients with residual hearing who are candidates for hearing preservation surgery or electroacoustic stimulation, also known as hybrid implants, we know that these patients' postoperative hearing outcomes depend on maintaining low frequency acoustic hearing. And further, even in patients with conventional cochlear implants, hearing preservation techniques can lead to better speech understanding and noise, appreciation of music, and improved sound quality, among other benefits. Due to the variability in hearing performance with CIs and hearing preservation outcomes, some potential cochlear implant candidates who would otherwise be good candidates are reluctant to undergo surgery. This presentation started with a simple sounding question: how do we best place cochlear implant electrode arrays to give patients the best opportunity for success in their hearing rehabilitation? As is often the case in medicine, the answer is far from simple or straightforward. This presentation isn't meant as a how-to guide for performing cochlear implant surgery, nor a discussion about the management of cochlear implantation in cases of congenital ear malformations or difficult revisions. But what my goal is to cover is what the research shows regarding how cochlear implant electrode array selection and the insertion can affect patients' postoperative hearing outcomes. One recommendation for referring patients with hearing loss for a cochlear implant evaluation is the 60-60 guideline. Patients are referred for evaluation if they demonstrate best ear unaided monosyllabic word score less than or equal to 60% correct, and an unaided pure tone average in the better ear that's worse than 60 decibels. And with the expansion of criteria for cochlear implant candidacy, including greater degrees of residual hearing prior to implantation, it becomes even more important that we identify and address the surgically modifiable factors for this surgery. These include everything from ensuring that the electrodes are in close proximity to the neural elements that they are intending to stimulate, to reducing the trauma caused by the insertion itself. And to understand what could constitute the ideal electrode array insertion, we need to know more about what can go wrong, or the ways in which electrode arrays placement can fall short of the ideal, how often these happen, and also how we can detect and correct these problems. Overall, the incidence of trauma with cochlear implantation is far from negligible. with a systematic review of 21 studies, finding a 17.6% of patients implanted showing evidence of trauma. While the rates of cochlear implant revision is low, a series of 58 revision CIs found that in 13% of these cases, the revision was due to the need to optimize the electrode array placement. Ideally, these cases would be avoided by better placements at the time of the initial surgery. These two diagrams show some of the described problems that can occur with electrode array insertion. Ideally, the electrode array will be fully inserted into the scala tympani with all the active electrodes able to stimulate the target neural elements. A number of complications have been described, including incomplete insertion, kinking, tip fold over, scalar translocation, and electrode migration. Besides mispositioning of the electrodes with these complications, these can result in significant trauma to the delicate intracochlear structures. As for the first one, in tip fold over, the tip of the electrode array folds back on itself, usually due to resistance to insertion while advancing the array. Tip fold over is generally not immediately identifiable clinically based on resistance that the surgeon can feel during the insertion, but it can be definitively shown on imaging such as X-ray or CT. If this is identified intraoperatively, the electrode array can be repositioned. Postoperative treatments, if the tip fold over is not previously identified, can include deactivating the involved electrodes to improve performance by reducing interference between electrodes in the folded over tip, but this reduces the number of active electrodes able to stimulate the cochlea. Electrode kinking occurs when a portion of the electrode array has buckled or twisted on itself due to resistance to insertion while advancing the electrode rather than going in smoothly. Similar to tip fold over, this is not readily noticeable to the surgeon, but can be identified on imaging obtained after insertion of the electrode array. Electrode under insertion occurs when the electrode has not been advanced sufficiently so that all the active electrodes are within the cochlea. Extrusion can also occur, in which case the electrode array has slipped back through the round window or a cochleostomy after insertion, leaving one or more electrodes that are no longer able to stimulate the cochlea. This can occur well after surgery due to forces acting outside the cochlea, such as certain disease processes, or from ossification of the cochlea, or even stiffness of the electrode array itself. These two diagrams shown here on this slide show imaging and the immediate postoperative period, verifying complete insertion, followed by follow-up insertion, follow-up imaging demonstrating partial extrusion of the electrode array. In a systematic review of 26 studies, the most common presenting symptom prior to identification of electrode migration was a change in sound perception or poor performance with the implant in 43 patients, followed by pain sensation in 15 patients, and facial nerve stimulation in 10. Cholesteatoma was the most common associated pathology in 10 patients, followed by infection in 9, and ossification of the basal turn of the cochlea in 8 patients. A number of authors have described methods to reduce the risk of extrusion, including packing temporalis muscle or fascia at the site of insertion, applying fibrin glue in the facial recess to mobilize the array, or even suturing the electrode array to the incus buttress. Children may be at higher risk of electrode migration due to their growing mastoid cavities. Fortunately, implantation at a younger age hasn't been found to be associated with elevated rates of migration. In a study of 26 children implanted prior to age 2, evaluation with X-rays intraoperatively and again on a yearly basis did not reveal any cases of migration. In standard cochlear implantation, The electrode array should be situated entirely within the scale of tympani. If the electrode array translocates from the scala tympani into the scala vestibuli, it can damage both the basilar and Reisner's membranes and possibly the organ of Corti and the osseous spiral lamina. While plain X-rays or CT with a cone beam or multi-detector helical CT can identify tip foldover or kinking of the electrode array, scala translocation isn't always that easy to identify. Conventional imaging techniques don't show the boundary between the scala within the cochlea and the metal electrodes themselves create artifacts on imaging due to their density. Scalar translocation has been studied in histopathology of human temporal bones initially. In this histology figure to the right on this slide, part A1 on the top, shows the electrode of a House 3M cochlear implant initially going through the round window into the scala tympani. The electrode traverses the scala tympani to the anterior part of the cochlea. And then in part A2, shown here in the middle on the right, at the anterior inferior basal turn, the electrode translocates through the osseous spiral lamina and basilar membrane. And then in part A3 on the bottom right, the electrode can be seen located in the scala vestibuli. The arrowhead shown in the figure points to the site of translocation between the scala. Histopathology slides, however, can only be used in post-mortem examination rather than in vivo, and even potentially the most useful at the time of implantation when it would allow adjustments to be made. In the figure on the bottom left of this slide, there's a reconstructed CT image showing translocation of an electrode array from the scala tympani, shown in red, to the basilar membrane and to the scala vestibuli, which is shown in part B. In this diagram, in the first study by Lane and colleagues, they were able to confirm the scalar location of the electrode array in 70% of the 23 implants studied with using a 64 slice multi-detector CT using multiplanar oblique projections. In the other 30%, however, of cases where the location of the implant in the basal turn was indeterminate, underlying disease states such as congenital malformation, labyrinthitis ossificans, or retrofenestral otospongiosis obscure the definition of the bony margins of the cochlea and prevented an accurate assessment of electrode array within the basal turn. In this figure from a paper by Dansing and Jolly, pre-curved electrode arrays such as the contour advance at a much higher rate of translocation compared to the straight electrode arrays also shown in this diagram, including the Cochlear CI422 slim straight, as well as the Med-L Flex series. Scalar translocation may also depend a lot on the type of electrode array as well as the trajectory into the basal turn of the cochlea. In the results shown here from a number of different papers for patients implanted with pre-curved arrays stratified by cochleostomy versus round window or extended round window approaches, there's a wide range in the proportion of patients with scalar translocations with high rates of translocation still being reported in papers published in the past 10 years, making this an area ripe for improvement. One of the prerequisites for addressing these problems of electrode array insertion is the ability to accurately and reliably detect them. Beyond that, we need to be able to act on the information to change the position of the array within the cochlea. Plain X-rays can be used to image after a cochlear implantation to verify that the electrode array is in the cochlea, to measure the angular insertion depth, and to look for tip foldover or kinking. But an ideal imaging modality would also give us sufficient resolution to be able to identify the location of structures within the cochlea, measure an individual patient's cochlea, both the length of the cochlear duct, but also the cross-section of the scala tympani along the lateral wall and close to the medialis to determine how a patient's individual cochlear anatomy will influence the planned implantation. Fortunately, there's evidence that scala translocations can be addressed intraoperatively. In the study by Morel et al., 5 out of 6 translocations in cadaveric specimens implanted with recurved CI532 electrodes were able to be corrected with removal and reinsertion of the electrode array. The need for better techniques to examine the cochlea has also led to investigations into other imaging and computational methods to examine cochlear microanatomy. Common histological slicing and staining techniques proved to be unsuitable for bones implanted with electrodes containing these metallic wires because the sectioning knives can't reliably cut through them. Cutting through the wires introduces significant artifacts in the tissues softened in the decalcification process of preparing these slides. And the tissues can get damaged when the wires are stretched on the cutting knives. Another histologic technique known as grinding and polishing can be used on non-decalcified bone specimens or bones containing metallic electrodes and wires. However, extensive sample preparation and embedding in acrylic resins applied in this technique, as well as the replacement of the cochlear fluids by the resins, increases the risk of introducing preparation artifacts to the examined sections. X-ray microtomography or micro-CT enables nearly artifact-free examination of the samples. In this diagram shown here on the right of this slide, there's a comparison between a cross-section obtained with classic histologic techniques on the top picture, and then a virtual cross-section of the cochlea obtained by micro-CT in the image below that allows us to distinguish between the scala tympani and scala vestibuli. Another technique, synchrotron radiation phase contrast imaging, has been used to examine cadaveric temporal bone specimens in a high level of detail. The 3 images on the left of this diagram show mid-medullary 2D slices of 3 different cochleas using synchrotron imaging compared to the corresponding micro-CT images on the right. The synchrotron images show a complete separation between the scala tympani and scala vestibuli by the basilar membrane and the basal, middle, and apical turns within the images obtained. The synchrotron images also show a more detailed view of other cochlear structures, including the spiral ligament, stria vascularis, cochlear nerve fibers, and the spiral ganglion. Together with micro-CT imaging, human temporal bone studies performed with synchrotron imaging have been used to create 3D renderings of cochlear anatomy, enabling precise delineation between structures and measurements of anatomic variations. This diagram shows a 3-dimensional rendering from cochlea image obtained with synchrotron imaging, showing the basilar membrane, peripheral axons, and spiral ganglion, represented by different colored bands divided by octaves. The round window is also shown here in the right of the image in green translucent color, with the scala tympani shown in translucent red and the scala vestibuli in translucent blue. The smaller images on the left of the diagram show a comparison in the resolution between clinical cone beam CT and part A on the top left, micro CT in part B in the middle, and then a synchrotron image in part C on the bottom left. These studies have enabled a greater understanding of cochlear anatomy and the variations between patients. This diagram depicts measurements recorded at a mid-medullary slice. The cross-sectional diameter of the scala tympani, defined as the largest inscribed circle within the scala, is identified in the yellow circle on the left diagram. The most lateral location, which can contain a 0.4 millimeter circle, is shown in blue in the center image. And then on the right, the XY plane is shown in the dashed white line, and the scalar width along that long axis is illustrated in this light purple line, and the scalar tilt angle between the two is illustrated with a solid gray arc. Together, measurements such as these can give us understanding of how a selected electrode array can fit into a patient's cochlea, and this also allows us to pave the way for individualized surgical planning and identifying how to avoid complications. The next frontier in CI imaging is using what we've learned from these anatomic studies to apply to management of patients in real time for pre-surgical planning, intraoperative quality control, and postoperative analysis and programming. A number of groups, including researchers at Vanderbilt University, Advanced Bionics, and Oticon, have used statistical shape model algorithms and machine learning for image analysis to reliably predict location of anatomic structures and implant electrodes in clinical images. The diagrams shown here show one such application of automated image processing to create a 3D rendering of an electrode array within a cochlea based on a clinical CT exam. In addition to imaging for pre and post-operative analysis of cochlear anatomy and electrode array position, electrophysiology is an active area of study for intraoperative evaluation and cochlear implantation. And one technique measuring the spread of excitation by stimulating with one electrode and measuring at other electrodes can determine whether electrodes are unusually close together, as occurs with tip foldover. This schematic drawing of a normal spread of excitation curve at the top diagram and an electrode array that's folded over on the bottom, and their accompanying spread of excitation curves show this difference. The probe electrode in these images is drawn at electrode number 10. And in the bottom image, the upward spread of the second curve indicates a fold over at approximately electrode 15, with the amplitude increasing from electrodes 16 to 18 rather than decreasing, indicating that these higher numbered electrodes are getting closer to the stimulating electrode rather than farther away, as would be expected in a normal insertion. Intraoperative electrocochleography can detect electrophysiologic changes during electrode insertion that may predict trauma and conversely predict hearing preservation. Studies have evaluated the use of ECOG to provide feedback to the surgeon regarding whether an insertion is causing trauma so that adjustments in technique can be made. In one study of 27 patients by Mandela and colleagues, hearing preservation was achieved in 11 out of 13 patients, or 85%, implanted with ECOG feedback, compared with only 33%, or 4 out of 12 control patients. Investigations are also using ECOG to predict tip rollover and postoperative hearing performance. Besides malplacement of the electrode array itself, avoiding trauma to surrounding structures in the cochlea is an important part of optimizing electrode array insertion. All of these studies encompassing histopathology, imaging, electrophysiology, and patient postoperative outcomes have identified a number of ways that the cochlea can be damaged during cochlear implantation. These include everything from direct mechanical trauma from the electrode array or hydraulic forces transmitted from the array to the perilymph within the cochlea, as well as non-mechanical injuries such as acoustic trauma from drilling and disruption of the labyrinthine fluid homeostasis, which can occur with soiling of the perilymph within the scala tympani. All these efforts have come together as part of what's termed soft surgery techniques and hearing preservation techniques. Research has identified surgical techniques including slow, steady insertion of the electrode array to decrease hydrostatic forces of the perilymph within the cochlea. To avoid translocation, it's recommended that the vector of insertion be parallel to the long axis of the cochlear basal turn. Postmortem temporal bone studies show that cochleostomy approaches are more likely to result in scalovestibular fibrosis and endolymphatic hydrops when compared with round window insertions. And lower drill speed when removing the round window overhang may reduce the transmitted forces to the cochlea that can cause trauma. Corticosteroids are commonly given to reduce inflammation, but it's unclear yet what the best dosage of or route of administration is. Other medications and techniques, including robotic assisted insertion, are under investigation. The focus on improving hearing outcomes, whether as part of a hearing preservation surgery or just to reduce the risk of trauma to the cochlea, has fortunately led to demonstrated practice changes as well. This diagram shows the change in response to a survey distributed to surgeons attending the William House Cochlear Implant Study Group in 2006, and then a repeat survey in 2012. In the follow-up study 6 years later, more respondents reported round window insertions and the use of anterior inferior cochleostomies when used, as shown here in this table. Round window insertion went from 19% in the original survey to almost 70%. So far, we've discussed how the cochlear implant electrode should be positioned within the scala tympani. Another important topic is how the design of the electrode array fits into our goals of optimizing electrode array insertion and ultimately how patients perform with their implants. Ideally, the electrode array chosen for a patient should be able to stimulate the neural elements across the cochlea and reduce the distance between the electrodes and the neural elements, all while minimizing the trauma caused by the insertion. There have been a relatively large number of implant models created over the years with some very different dimensions. In this diagram, the y-axis is the cochlear length at the organ of Corti in the corresponding Greenwood frequency map. The bars in the diagram show the full array length, and the arrows within the bars show the active stimulation length. Part of this is related to different ideas on how the neural elements should be stimulated and how we should balance coverage of the length of the cochlea with the risk of trauma with insertion. The organ of Corti extends to the full length of the cochlea, but the spiral ganglion cells inside Rosenthal's canal extends about 1.75 to 1.85 turns of the cochlea, which is equivalent to an insertion angle of 660 degrees. The Macuda synchrotron imaging study that we discussed in a previous slide depicted variations and narrowing in the basal turn at around 180 degrees. And this is also borne out in histopathology slides. Ishiyama found that pre-curved electrode dislocations were located at an angle between 170 and 190 degrees. And in this diagram on the bottom of this slide from a recently published paper by Girardin et al., different patterns of trauma have been observed between straight and pre-curved electrode arrays. Here in this diagram, trauma to the osseous spiral lamina is shown in red, while trauma to the spiral ligament is shown in blue. And these two parts of the diagram show different patterns between the straight electrode arrays on the left versus the pre-curved arrays on the right. Longer electrode arrays and deeper insertion have additional risks. In this diagram, the x-axis shows the insertion depth in both millimeters and angular insertion within the cochlea. The y-axis shows the insertion force. The gray area shows a published range of insertion force profiles and lateral wall electrode arrays in the image on the left, and then standard insertion of a stylet-based perimetallic electrode array on the right. The dashed line in the image on the right shows the insertion forces for the advanced soft stylet insertion technique. The red shaded area shows the range and forces measured in vitro to cause a rupture or translocation. With deeper insertion, the electrode array must pass through narrower portions of the scala tympani and displace additional perilymph, which can result in greater hydrostatic forces, among other sources of trauma. To further complicate the discussion on precurved versus straight electrode arrays, the precurved arrays used in the last few years, such as the CI 532 and 632, aren't the same as the older precurved arrays, including the Cochlear Contour and Contour Advance, which use an internal stylet. And further, it can depend a lot on a patient's individual anatomy, whether they're at higher risk of scalar translocation. In a study by Eisenhut et al., they found that in patients with scalar translocations, there were significantly increased amounts of narrowing of the proximal segment of their basal cochlear turns. And as mentioned at the beginning of the presentation, all these efforts to reduce trauma to the cochlea and preserve normal anatomy have real benefits for patients. And the study highlighted here, which included precurved and straight electrode designs from different manufacturers, hearing preservation was observed in 55% of patients. Patients with hearing preservation had higher postoperative speech perception performance in the CI-only condition than those who lost all residual hearing. And in this study by Woodson et al., patients implanted with slim perimetallic arrays an equivalent proportion of hearing preservation as patients implanted with slim lateral wall arrays. Their data was relatively comparable to a number of prior studies on hearing preservation with slim lateral wall arrays that are also shown in this table. In another study, Nasiri and colleagues studied 24 adults implanted with Cochlear CI 532 electrode arrays and similarly found that precurved electrode array insertion using external sheath can maintain hearing preservation rates comparable to straight electrode arrays. In their sample, there was one scalar translocation and no tip foldovers out of all the 24 patients. In single institution studies comparing patients implanted with precurved versus straight electrode arrays from a single manufacturer, Holder et al. Found that their precurved CI 532 group showed either a similar or a statistically superior results on all measures when compared with a straight electrode array, a CI 422 and 522 group. Schromer et al. Found significantly higher CNC and AZ-BIOS scores for patients with precurved electrode arrays compared to patients with straight arrays when controlling for age, preoperative hearing status, and follow-up time. And they found no significant differences between hearing preservation rates between electrode array types. In comparison of newer slim medullary electrodes, such as the CI 532 to the Contour Advance electrode, the 512, studies have shown that scalar translocation is not necessarily a fundamental problem with perimetallic designs. Multiple authors note that there's a learning curve with perimetallic arrays compared with straight electrodes. Now that the designs are available to insert perimetallic arrays in ways that allow full scala tympani insertion with the possibility of hearing preservation and improved hearing techniques, then we have to question some of the earlier assumptions about precurved versus straight electrode arrays. Together, these data show the feasibility of precurved arrays for hearing preservation and the changing landscape of cochlear implants within the last few years. While depth of insertion has been shown to be a significant predictor of hearing outcomes with straight electrode arrays, proximity to the proximity of the electrode array to the medulus and complete scala tympani insertion have been found to be significant factors in hearing outcomes in patients with precurved electrode arrays. Although one study highlighted here found that medullary proximity in the basal third may have a greater impact on speech perception. Manipulation of the electrode array after insertion has also been described to reduce the distance of the electrodes to the medulus. In one study using the pullback maneuver, the average ECAP thresholds on electrode channels was significantly lower, especially in the upper basal and middle cochlear region, shown here in the diagram from electrodes 6 to 12, compared to those using conventional insertion. However, in contrast, at least in this study, the pullback maneuver assisted insertion led to significantly higher ECAP thresholds in the basal cochlear electrode channels, shown here in the diagram in electrodes 2 and 3, compared to the conventional insertion. Reducing the distance of electrodes to the cochlear neural elements can reduce the spread of excitation from the electrodes and may lead to improved hearing outcomes. If we know that patients have varying anatomy and this affects how an electrode array will interact with the patient's cochlea, the next question is how we can use this information to change the surgical plan. In a study by Labadie and Noble, they evaluated cochlear implantation and cadaveric specimens, giving the surgeon an insertion plan in text format that was created from an analysis of preoperative imaging in the experimental group compared to a suboptimal plan that was chosen for the control group by selecting an approach that was within the range of normal, yet was predicted to result in comparatively poor final electrode location compared to the experimental group. The text on this slide shows one such surgical plan with instructions such as insert through the round window membrane and choose an entry angle to pass through the middle of the facial recess. They found decreased perimedullar distance and higher rates of full scalar tympani insertion with this image-guided planning. Tying some of the concepts presented together, it's really when the patient's anatomy, the implant design, and the surgical technique all come together that we can get the best hearing outcomes for our patients. There are still many unanswered questions and opportunities for improvement in cochlear implantation. The literature is often limited by being based largely on small retrospective studies, which can make it challenging to determine exactly why certain patients perform better with cochlear implants than others. Implant designs and surgical techniques have changed over time. Researchers have been developing reporting standards, including the minimum reporting standards for adult cochlear implantation, which was published in 2018 and defined functionally relevant preoperative low frequency pure tone average as measured at 125, 250, and 500 hertz as being below 80 decibels. But even with these standards, there's debate about whether this is the best threshold to use, and overall reporting of data in CI research is heterogeneous. And despite that heterogeneity in the literature, there are a few important takeaways that we can garner from recent investigations. Optimizing electrode array insertion and avoiding complications is one area in which we can improve hearing outcomes in patients with CIs. This can lead to improvements in word and sentence recognition, which form the basis of evaluating candidacy for implantation, as well as evaluating postoperative performance and potentially help patients with hearing in difficult listening environments, such as hearing in noise. Imaging can provide guidance on electrode insertion and verification of electrode positioning. And in the future, it may become a more routine aid in determining patient customized electrode arrays. So there's certainly an exciting future in terms of determining the best ways that we can further optimize electrode array for our patients. I have a ton of references in case anybody's curious where these different diagrams and figures came from.